This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 15, Addiction Disorder, Alcoholism. Key concepts. Upon completion of this chapter, you will understand that alcoholism is a multifactorial chronic disease. The ways the disease of alcoholism affect the body's vital organs, including the brain, heart, lungs, digestive organs, as well as altering endocrine, hematologic, and neurologic function. The way deprivation of ethanol alcohol may lead to the alcoholic to seek more toxic substances, and the recognition that alcohol withdrawal and acute alcohol poisoning are medical emergencies. So chief concepts. Important concepts to remember be differentiation between dementia and delirium. Now, dementia is a progressive and permanent deterioration of mental function, while delirium is acute, short-term. It could be reversible. Impairment of cognitive function is what delirium means. Alcoholism is a chronic disease. Influences and features of this, the influences are genetic, psychosocial, and environmental. All of those can help harbor alcoholism. Features of alcoholism: inability to control alcohol consumption, constantly driven to find alcohol, preoccupied with drinking, and experiencing adverse consequences as a result of drinking. Scope of the problem: over 160 million Americans of drinking age, and an estimate 7 million or so are considered alcoholics. Residual effects: 1 in 3 rapes, 2 in 5 assaults, and 3 in 5 cases of child abuse involve alcohol. An estimated 25,000 Americans will die each year in alcohol-related crashes. And we're going to look at a couple tables here. Table 15.1 is differential diagnosis for delirium, and Table 15.2 is the CAGE alcohol assessment tool. So this is 15.1, differential diagnosis for delirium. And these are all the things that can cause delirium besides alcohol. So infection, withdrawal, and this would be from alcohol. Acute metabolic causes like hypoglycemia, trauma, central nervous system seizures, hypoxia, deficiencies in vitamins, more specifically the B vitamins, thiamine, endocrine hyperglycemia, acute vascular disorders like a migraine, toxins and drugs, and then heavy metal poisoning. All of those can create delirium. And this is the CAGE assessment tool. C-A-G-E. So, first of all, have you ever tried to cut down on your drinking? Are you easily annoyed when people criticize your drinking? Do you ever feel guilty about your drinking? Do you need an eye-opener in the morning? So, more of those questions are asked, and the more of those that are answered yes, that would be one of the tools to start thinking maybe possibly alcoholism. Pharmacokinetics of ethanol. This is going to be a little long on this one. It's pretty much a sedative hypnotic. It mimics benzodiazepines. Pharmacodynamics acts in various ways in the central nervous system. As an antagonist to acetylcholine, as an agonist to the inhibitor neurotransmitter GABA. Now, GABA is the same thing. Whenever we give somebody Valium, it also works on the GABA receptors. The alcohol works on several others, though. Alcohol affects the GABA receptors. Alcohol acts as an antagonist on the excitatory neurotransmitter glutamate through the NMDA receptors. That's also where ketamine actually works. Effects of alcohol are often dose-related, so the more alcohol you get on board, the more effects or the more potentiation that you get. Tolerance and dependence. Though its effects on the limbic system, alcohol lowers inhibitions and may increase violence. People may continue to drink and develop a tolerance. Chronic heavy drinkers leads to an irreversible drug-induced brain syndrome typified by clouded sensorum or sensory input, disorientation, and diminished intellectual capacity. Drug interaction with alcohol. Treatment plans of alcoholism may include disulfiram or antabuse, and this kind of discourages drinking by making the person very sick whenever they drink it. Fetal alcohol syndrome. Alcohol can lead to birth defects. 30 to 50% of infants born to mothers who are drinking alcohol during pregnancy. Identification of these children. Wide-set eyes, flat bridge of the nose, small cheekbones would increase the possible chances or the thought process that they might have had fetal alcohol syndrome. Hyperactivity, mental retardation, and difficulty in social integration. Health implications of chronic alcoholism. We get things like pancreatitis and jaundice. Pancreatitis is an inflammation of the pancreas, typified by sudden severe pain in the epigastric area, radiates into the back. Commonly occurs only 1 to 2 hours to several days after a bout of drinking. Inflamed pancreas can no longer produce the enzymes that it needs to. Jaundice and liver disease are several little terms in this as well. Please look over these in your book. Hyperbilirubinemia, which means increased circulating levels of bilirubin in the blood. Jaundice is something that we see, a yellowish color to the sclera, the whites of the eyes, and or yellowish tinge to the skin that can occur. Pruritus, itchiness that presents secondary to the buildup of bile salts underneath the skin. It also is associated with jaundice. Table 15.3 we're going to look at next. These are drug interactions with alcohol. And prolonged actions of antihistamine, barbiturates, benzodiazepine, opiates, and phenothiazines, things like phenagrin or phenothiazines. Shortened half-life, and this means that the medicine isn't as effective. Propanolol, isoniazid, phenobarbital, phenytoin, and warfarin. 2 of these are seizure medications here. This adjusts your ability to clot. So this is used to adjust people's INRs whenever they're wanting to Coumadise them. Like say the patient has AFib, or keep their blood from clotting so much or having the ability to clot. Alcoholic liver disease includes a fatty liver disease. Distension impairs circulation and distribution of the blood within the liver. Eventually, this causes the liver cells to swell and or rupture. Steatosis are globules of fat that become stored in vacuoles in the liver cells. Alcoholic hepatitis, complex inflammatory immunological response that is a result of oxidation of alcohol. Hepatomegaly, which is swelling of the liver. Liver cirrhosis, degenerative disease of the liver. Androgens, liver modifies or inactivates certain hormones. Levels of estrogen are higher and levels of circulating testosterone are lower. Results in hypogonadism and femidization in a male, as evidenced by the development of breasts in men. Hyperinsulinemia results from factors combining to promote hypoglycemia, inhibit glycogen production, and limit gluconeogenesis, the production of glucose from substrates. Conditions associated with liver disease: impaired protein synthesis. We should always watch for ascites, which is the presence of fluid in the peritoneal cavity. And this occurs because of backup of the portal artery and the portal circulation system to the liver. Coagulopathies, circulating coagulation factors not removed or capable of stimulating the coagulation cascade. This could lead to DIC or disseminated intravascular coagulation. Portal hypertension and esophageal varices. Like I said, the liver is very fatty. It's kind of clogged up. It backs up. So all the veins bulge, including the ones in the esophagus, because all of the intestinal area is filtered through the liver before going back into central circulation. Portal hypertension. Blood flow is impeded and backs up into the portal vein. Caput medusa. Umbilical veins are visible under the surface of the patient's skin. Esophageal varices are distended veins in the esophagus. Sclerotherapy, process of injecting a vein with a caustic substance that causes blood clot formation or thrombosis. Renal failure is also a consideration, maybe due to a combination of sympathetic nervous system, vasoconstriction, or from direct renal insult from the toxins that would normally be detoxified in the liver. Key concepts on this: hepatorenal syndrome, acute tubular necrosis occurring in the kidneys, leading to acute renal failure. Azodemia, accumulation of nitrogenous waste. Uremic frost can also be seen sometimes. Wastes are excreted through the sweat glands and form crystals on the skin after the sweat evaporates. Anascara, total body edema. Hyponatremia can also be caused, which is low sodium levels, results in a change in the body's osmolarity. And osmolarity of the blood is partly a function of the amount of blood proteins in the blood. So whenever we have low protein levels from liver failure, very simply, it adjusts the colloidal osmotic pressure, or the ability for us to move fluids in and out like we normally would. Conditions associated with liver continued. There are cerebral syndromes like Wernicke's-Korsakoff, loss of specific brain function, which can be attributed to thiamine deficiency. Korsakoff Syndrome involves behaviors that can be attributed to severe impairment of memory, and this would be like antegrade and retrograde amnesia. Wernicke's-Korsakoff syndrome and glucose administration. In EMS, we've stopped really using or practicing the administration of thiamine before glucose. If Wernicke's-Korsakoff is suspected, following physical examination of the patient with alcoholism, then 50 to 100 milligrams of thiamine may be administered. Acute liver failure, rapid deterioration of liver function, and it's a true medical emergency. We can get hepatic encephalopathy, potentially reversible metabolic derangement, which affects the brain, causing it to be dysfunctional. Ammonia levels are a key metabolite that has been implicated with certain hepatic encephalopathies, and elevated ammonia levels in the blood, they lead to cerebral edema, increased intracranial pressure, and death. Cerebral edema, last one on our list here, leads to an increased intracranial pressure because the brain swells, has no place to go because of the skull. Acute alcohol poisoning. Ingestion of excessive quantities of alcohol within a shortened period of time leads to a peak alcohol level greater than 0.40 grams per deciliter. Important concepts in the treatment of alcohol overdose: be sure that we maintain their airway, intubate them if necessary, use short-acting sedatives, evacuate their stomach if possible, be sure that we assure their respiratory status, and be sure we have intravenous access. Ethylene glycol, methanol, and isopropyl poisoning, isopropyl alcohol poisoning. Ethyl alcohol is a popular substance used in alcoholic beverages. Isopropyl alcohol, used as a cleaner and as a gasoline additive in dry gas. Methyl alcohol, simple, sweet-tasting alcohol that is extremely volatile and is used in things like antifreeze, fuels, and biofuels. Ethylene glycol, it's a dangerous form of alcohol, used as antifreeze for radiators and as de-icer for aircraft, which leads it to a wide distribution. Table 15.4 on the next page here is blood alcohol concentrations to clinical presentation. And from 0.01 to 0.12, we get things like euphoria and the loss of inhibition. From a 0.1 to a 0.25, lethargy, somnolence or drowsiness. 0.25 to 0.40, we get stupor and the patient's difficult to arouse. 0.35 to 0.50, coma and unconsciousness, and possibly death. History. The main criteria and concern that we're worried about as far as death goes is they have altered their LOCs, they lose their ability to control their airway, and hypoxia sets in. Considerations. Protocols, when taking a history, remove the patient from the alcohol and distance the patient from any family or friends who may agitate him. History should be as short as possible. Do not attempt to force answers and attempt to remain non-judgmental but firm. Symptom complex, hepatic disease symptoms, pruritus, itchy feeling, not relieved from scratching. Acute infection may cause patients with alcoholic liver disease to decompensate. Allergies and pertinent past medical history, diagnosed from various chronic diseases, things like diabetes, co-diagnosis of seizures, pancreatitis, or the vomiting of bright red blood. Medications and last meal, drug history, any new prescriptions, any changed prescriptions, or non-compliance with prescribed medications, their dietary status, last meal and last drink, and events preceding. If there's any kind of possible trauma, focus on the trauma and their mental status. Examination. Procedure. Start with the vital signs, hyperdynamic characteristics of alcoholic liver disease. Perform a head-to-toe examination, head, scalp, ears, eyes, nose, upper chest and breath, abdominal exam, extremities. Patients with chronic liver disease often have thin arms, sometimes described stick-like, secondary to muscular atrophy. Liver flap, they may also have that as well. Hands of the patient with alcoholic liver disease, particularly those with hepatic encephalopathy, will tend to tremor in a flapping motion. Palmar erythema, redness to the palms. Treatment. Considerations focus on eliminating obvious etiologies, hypoxia and hypoglycemia. Protective measures of airway management and possible endotracheal intubation, risk versus benefit. Maintain adequate cerebral perfusion and decrease any kind of intracranial pressure if possible. Psychological first aid should be rendered first. Fear leads to agitation of delirious patients, reducing anxiety and agitation, provide emotional support, continuous reorientation to reality, assistive technologies for any kind of impairment that they might have, defuse and de-escalate the scene, ensure adequate lighting, and decrease any kind of ambient noise. Evaluation. Acute alcohol withdrawal is a potential life-threatening emergency, particularly with a history of prior alcohol withdrawal attempts. Every year, over 2 million Americans will experience alcohol withdrawal. Less than 20% will be medically monitored. Pathophysiology of alcohol withdrawal. Alcohol enhances the inhibitory neurotransmitter GABA, leads to sedative effects. Chronic alcohol abuse results in desensitization of the brain. Similar patterns, kindling, impact or repeated prior detox attempts on the brain. Each detoxification tends to increase the patient's desire for alcohol. Suggests that with each attempt at alcohol withdrawal, the patient will become increasingly more symptomatic. Autonomic hyperactivity, symptom pattern associated with alcohol withdrawals. Delirium tremens, triad of confusion, delirium, and seizures. Treatment focuses on decreasing autonomic stimulation and correcting anti-fluid deficits. Mainstay of pharmacology treatment for people with alcohol withdrawal has been benzodiazepines, things like Valium, Versed. Disposition. Alcoholic liver disease, complex multi-system pathology. Patients must be directed to medical care to prevent further deterioration. In conclusion, addiction disorders, common across all socioeconomic boundaries. Withdrawals can cause significant physical problems, may not be immediately apparent though. We should always consider this with altered mental status or any type of delirium that they might be in alcohol withdrawal. References for this chapter were taken from Myers and Beebe, Professional Paramedic, Volume 2, Medical Emergencies, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandscc.edu, or 405-219-7613. Thank you.